Obviously, the news of today will still be primarily focused on Omicron and what looks to be a tidal wave of Omicron coming our way, and unfortunately, from which there does not appear to be an escape. And this is something that Boris Johnson mentioned to the British people 2 days ago, warning of a tidal wave of Omicron coming to the UK. And as I've mentioned, the UK, I think, is a good harbinger of what's coming our way. They have a bit of a head start on Omicron. Also, they happen to have a much better public health surveillance system nationally than we do, so have much more acute awareness of where Omicron is. So a couple of interesting documents that have come out of the UK in the past couple of days. This was a technical briefing from their health security agency, a new entity that was stood up during the pandemic in response to the gaps that were recognized. So a couple of things in this technical briefing, just looking at the growth rate of Omicron in the UK, you can see that's a logarithmic scale there of increasing frequency of the S gene target failure. As we discussed, that's the PCR signature that is a good indication of the proportion of your cases that are Omicron, and the UK has almost half of their PCRs that they run in the country capable of finding that S gene target failure signal, and so they're seeing this dramatic exponential rise. So again, if you're linear on a logarithmic scale, that's an exponential growth function. And what they're finding is Omicron doubling about every 2.5 days, which is ridiculously fast. And I think we've mentioned that before. If you look, this is on a relative time scale. So counting, day zero is when the first cases of each of these new variants emerged in the UK. So you can see that Omicron is growing faster than any of the prior variants grew by a large margin. And that arrow points to the current Omicron curve. Again, that's a logarithmic scale. So when you're growing that steeply on a logarithmic scale, you're really skyrocketing up. So Omicron is outpacing anything that we've seen previously in terms of SARS-CoV-2 viruses. They're also noticing that Omicron is behaving in a way that makes it appear to be much more transmissible than other variants previously. This is comparing the rate of household contact transmissions between Omicron and Delta. And you can see that Omicron is probably somewhere between 2.5 and over 3 times as likely to transmit to household contacts as Delta is. And so this is obviously a huge growth in its ability to spread and transmit on from person to person. So taking some of the data that the UK has documented and some of the laboratory data that's come out in terms of neutralizing antibody titers and the significant reduction in neutralizing titers against Omicron that have resulted from previous infection and vaccination, the modeling team out of the London School of Hygiene and Tropical Medicine, which is one of the better modeling groups in the UK, put out this document 2 days ago that gives their current projections for Omicron. And you can see they ran through a bunch of scenarios and essentially created these 4 different scenarios in order from most optimistic to most pessimistic, essentially looking at what is the degree of immune escape. So is the virus able to escape immunity from prior infection and vaccination, to a low degree or a high degree? And then what's the effect of boosters? Will boosters have a high impact in terms of increasing that immunity, or will boosters have a low impact? And so looking at all 4 of those combinations, they were able to make a series of projections to look at what is coming to the UK. This is where the UK is now, just for point of reference. Again, over the course of the pandemic, the UK has experienced over 145,000 deaths, almost 11 million officially documented cases. And if you look at where they were in terms of their peak in January of 2021, which was the alpha peak in their previous high, their previous peak in confirmed cases in a day was roughly 60,000. and their previous peak in terms of number of COVID admissions in the hospital at any given time was about 38,000. So you can see that they're approaching their previous peak of cases, but they are still far below where they were in terms of hospitalizations, are now around 7,000 to 8,000 people in the hospital on any given day compared to the 38,000 where they were. These are the projections from the London School team, and first they kind of flex on how good their modeling is and how closely it approximates the previous true data that as the actually measured in the pandemic up until now. So just showing you that their modeling is outstanding, which indeed it is. And if you look at these various increasing severity scenarios, the dashed lines on each of these graphs represents their previous peak, their previous high back in the January wave. And then these projections take us from this month, December of 2021, up through August of 22, but that shaded window is kind of the acute period between now and the middle of April, when they expect an Omicron wave to play out. If you look at the left under panel B, that is the low immune escape, high booster efficacy. So that is the most optimistic scenario that they model. And still in that scenario, you can see that they far exceed the number of cases that was their previous peak last January. Over that time period through the middle of April, they estimate accumulating an additional 21 million infections or cases of Omicron during that period of time. During that period of time, they also estimate 175,000 hospitalizations. As you can see, they don't expect the peak to exceed the previous peak in January, but it should approach that peak. And obviously during that period of time, the UK health system was severely strained. If there is a silver lining or good news in that scenario, the number of deaths would not approach the peak that they saw previously, and they would add about 25,000 deaths to that 145,000 number of deaths that they've had already. But as you go across the scenarios of increasing severity to the worst case scenario on the far right on E, you can see that this essentially totally crushes the UK health system. So not only are cases dramatically higher than what they had previously seen in their peak, but their number of hospitalizations would be at least twice what they saw in their previous peak, which to the UK is completely unsustainable. And in fact, the previous scenarios of slightly lower severity also are beyond the capacity of the national health system to absorb. And you can see deaths would be higher than the peak of what they saw back in 2021. So these are not very comforting modeling scenarios coming from the London School. And again, a very capable and good modeling group with good history. So there's hospitalizations, again, showing you crushing those previous records with any of the three more severe scenarios. So the modeling conclusions say that they expect a substantial surge in cases from Omicron, a substantial surge also in hospital admissions and deaths, even in populations with high immunity like England. And as we know, we probably have much lower immunity than England and the UK on the whole, because of our lower vaccination rate in the US. So here are data, real data coming out of South Africa now that give us a little additional info on what's going on. Again, the health surveillance systems in South Africa are not as robust as what we get in the UK, so there's a lot of gaps. Even here, we have good data on cases from the entire country, but not necessarily broken down by province. And the only hospitalization data we have that are more accurate are from Gauteng province, which is again where the virus emerged, and the home of Johannesburg and Pretoria, so the two of the major cities in South Africa. So you can see cases are growing incredibly and have essentially achieved the previous highs in a much shorter period of time. However, hospitalizations, at least week by week, are growing exponentially, but at a lower slope or lower function than what cases are. And so this is prompting some unfettered optimism by lots of people in the media. And obviously it's a better scenario than having the same rate of hospitalization. But keep in mind, again, as we discussed, last week. These are primarily initially infections in young people. So we would expect hospitalization rates to be lower in that group. And also, we are very early in a rapidly growing epidemic, and so hospitalizations may not have had a chance to keep up. Now, hot off the press this morning, however, there's some additional data coming out of South Africa that do seem to support this idea that hospitalization rates are lower. I will add the caveat that this came from a press release from one of South Africa's largest health insurance groups. The primary data are not yet available, but this was announced today in South Africa, looking at recent cases of COVID-19, particularly almost 80,000 that are thought to be due to Omicron, and noticing that at least in this group, in this analysis, hospital admission rates were almost 30% lower than what they had seen in previous pandemic waves. So potentially a virus that is 30% less severe, or maybe has 60 to 70% the severity of what we've seen previously, again, which is better than more severe. But maybe not as good news as you might think. The other good news that came out of this study is there still seems to be very good vaccine effectiveness, particularly against hospitalization. The vaccine effectiveness rate for hospitalization right now appears to be about 70%. Again, remember, only about 25% or so of South Africa's population has been vaccinated. Vaccine effectiveness for infection, however, is dramatically reduced, only 30% compared to what current estimates are for fully vaccinated within 6 months with Delta infection. That effectiveness probably is somewhere more along the lines of 70 to 80%. So a significant reduction in the vaccine's ability to prevent infection, but still very good success in preventing hospitalization. So I thought it would be good to look at all these data and kind of digest for a second what this all means. And folks may have heard me over the last week or two say, if you have to choose between a virus that's twice as lethal or twice as transmissible, always choose the virus that's twice as lethal. And we'll talk about why. So let's do a little thought exercise about different viruses and their impact. So a couple of definitions just to remind everybody. R is essentially the effective reproduction number. So how many cases an infected case will pass the virus onto in the next generation. The IFR is the infection fatality rate, essentially what percent of people who are infected will die. And let's assume we have a virus, so the parent virus, the original virus that has an R value of 2 and an infection fatality rate of 1%. So that means if you're infected, you have a 1% chance of dying, and you have, on average, the ability to transmit that infection to 2 people. And so this is, not dramatically off from what the original Wuhan virus was. The R naught is a little low, or the R value is a little low, and the IFR is a little high. But we'll take this because it makes the math easier. And then let's assume that you have a generation time of 1 week. That means the time period between each successive generation of cases. So how long does it take one person to transmit to the next person and those people to manifest disease? And we're simplifying a bit, but it makes things a little easier, and also going with a week makes the calculations a little bit easier as well. So let's just assume that there's a new generation of cases every week, and let's run essentially a 2-month epidemic. So that would be 8 generations, right? 8 weeks. And we also need to assume at this point that the R value does not change over the course of that infection, which means you have an infinite pool of susceptibles, or at least you have such a large population that the number of infected is relatively insignificant compared to the larger population. And if you're looking at a large population like nationwide, or even a large state, over 8 generations of epidemic transmission for COVID, that's probably a rational assumption, and it will be at least close enough for demonstration purposes. So let's look at what happens. So here we have in the far left columns the parent virus, again, R value of 2, IFR of 1, and we're looking at a virus that is twice as lethal, that's variant 1. So again, same R value, but now an IFR of 2%. And then let's look, we will look on the right there at a virus that is twice as transmissible. So an R value of 4, but its infection fatality rate is still only 1%, the same as the parent virus. Now let's look at these first two viruses. So in the parent, in week 2, right, everybody transmits to 2 people on average. So you have 100 cases to start out with at baseline. In week 2, you generate 200 new cases, and therefore with an IFR of 1%, you would have 2 fatalities. When you have a virus that's twice as lethal, you get 4 fatalities in that week. So let's keep going every week. Week 3, 400 cases. Week 4, 800, 1600, 3200. This is the value of exponential growth, right? Just like your compounding interest, things get bigger and bigger the larger they get. So that by the time you're at week 7 and 8, you're producing a large number of cases, right? Almost 13,000 new cases in week 8, starting with only 100 cases back in week 1. Just like that old scenario where we talked about, filling up Lake Michigan. Exponential growth happens rapidly. And then you can see that with the parent virus, you would have expected 108 new fatalities at that period of time. And with the twice as lethal virus, you get 256 new fatalities in week 8. Now, that gives you over 500 fatalities for the twice as lethal virus compared to 255. So again, twice as many fatalities. The math is pretty easy. Now let's look at the virus that has twice the transmissibility. So now your R value is 4. So each case produces 4 new cases. So in week 2, instead of 200, you have 400 cases. Week 3, you now have 1,600 cases. Week 4, 6,400 cases, right? So now we're growing by a factor of 4 every time. By week 5, you already have over 25,000 cases, and you can see you've hit the 256 fatalities already in week 5. Now let's look at week 6, 100,000 cases, more than that. And you have over 1,000 casualties or fatalities in week 6, week 7, over 400,000 and 4,000 deaths. And then week 8, you now have 1.6 million new cases in week 8 and over 16,000 fatalities. So now with a virus that's just the same severity, the same lethality as the parent virus, but twice as transmissible, you've generated 2 million more cases, 2.15 million more cases in 8 weeks or 8 generations than you did with the parent virus. And you have essentially almost 100 times the fatalities that you had with the parent virus. So let that sink in for a minute. And this gives you an idea of why it's so much worse to have a highly transmissible virus compared to a highly lethal virus. Now let's take the best case scenario, and I did all this before this, 30% reduction in severity or lethality that we're seeing from Omicron, which you would think is maybe good news, but it's not even as good as this variant too. But let's be overly optimistic and say, okay, we have a virus that's now 10-fold less severe than the parent virus, right? So your fatality rate is 10-fold lower. So that's a fatality rate, an IFR of 0.1%. So when you run the math, it's still bad, because at week 8, you still have 1.6 million cases, which results in over 1,600 fatalities. And at the end of the day, you still have 10 times almost as many casualties as you had with the parent virus, and over 4 times the number of casualties you had with a virus that's twice as lethal. So this is a good thought exercise to kind of demonstrate why increases in transmissibility are so terrifying, and we really shouldn't be celebrating that much if the virus is a little bit less lethal. It's going to make up for it in volume. So that's all I have.